I started in the NIHR when I took over from Dame Sally Davis, and then I led it through till the middle of COVID when Lucy Chappell took over. Dame Sally and the team around her have done an amazing job of bringing together disparate bits of research as well as introducing new ones. Clearly we then needed to evolve it as things changed around us, but what I was taking over was a very good organisation. The NIHR is the principal route by which the government invests in direct health research to improve the health of the lives of people in the UK and more recently the lives of people internationally as well. It's done a lot of work on doing clinical things for people in hospitals. That might be diagnosis, let's say things like prostate cancer. It might be about treatment. It's done a lot of things on public health, trying to improve the prevention of health so that people don't get diseases in the first place. It does quite a lot on the basic and translational research, and that includes with industry and with charities, and it also works internationally with other colleagues around the world. The UK has an extraordinary tradition of doing really high-impact research to improve health in Africa and Asia and Latin America, as well as high-income countries. This includes diseases like TB, HIV, malaria, but increasingly non-communicable diseases. And this is an area where NIHR has provided a huge amount of support and allowed real improvements for health in people who've got the worst health internationally. NIHR had to move very fast during the COVID pandemic, and one of the first things that the government decided to do was to have research as one of our 4 principal aims. We did some of the best research in the world during that period and were the fastest to get many of the things out so that people would use them not just in the UK but internationally. So there were many things we learned which included accelerated approaches to getting rigorous but very rapid ethical review, working very closely with the regulators to ensure we could do safe research but do it at the fastest possible rate given the speed of the crisis. The public are the reason why we're doing research in the first place. The public as people who haven't yet got diseases we can prevent, who are patients who've got diseases we can treat. The public in NIHR's case are also paying for the research, so it is very much the public's research. And one of the things NIHR has done historically, much more I think than many other funders, is involve public and patient representatives in the design of research to ensure that it is actually the public's priorities that are reflected in what we do. When we're undertaking research, we do need to identify who are the groups who are underrepresented in research, and it's critical that we identify those and then we do something about it. The first is older people. Very often we've excluded people who've got multiple conditions. That means excluding many older people, and that means the research is no longer typical of the patients. It's no longer actually scientifically valid. Another example is people who've been very nervous about having pregnant women involved in research. What that means is research for pregnant women has moved much more slowly than for other groups. And a third might be minority ethnic groups who are very important as patients, and we need to make sure they are involved. So if the outcomes are different for them, we identify that and can optimise the treatment for those groups. If you look at the enormous changes that have happened to health, the reductions in infectious diseases, the reductions in cardiovascular diseases, increasingly reductions in cancer, very large portions of that are due to preventing disease. All of that is founded on really strong research. If you don't have the research, you can't, unsurprisingly, expect government then to make decisions to take quite difficult political choices. You can't expect investment. And if we wish to have less disease in the future, we have to continue to do research which is going to underpin future prevention, stop many of the diseases we have at the moment. Every generation has managed to hand on to the next generation better health than they inherited. Always that has been based on research. Every single generation will improve things, and if we continue to invest in NIHR, I would anticipate that we're going to improve health continuously for the next generation. NIHR has been able to achieve what it has principally because of extraordinary staff who really over the 20 years have built it up to be one of the most effective research organisations for clinical research, certainly in Europe, arguably internationally. And also to the patients and public who've taken part in our research, who absolutely underpin it. And finally, of course, to the scientists and other researchers and clinicians who've been involved in the research. And it's that combination with other funders, with structures like the NHS, that has allowed us to make the impact we have.